Welcome everybody to our webinar on co-creating digital public health interventions. I am extremely delighted to have such an amazing panel here with us that are far more advanced in co-creating than I currently am and potentially ever will be. So very happy to have you all in this workshop shared by the German Public Health Association and the Leibniz Science Campus for Digital Public Health. A few things for the agenda, as I've already said. I will briefly introduce you to the topic on concept of digital public health and co-creation, and also present to you our fantastic speakers. They will then give a short presentation followed by a short Q&A session, and then we will have an open discussion on all the burning questions that you might have. Unfortunately, my co-host is not here with me today, Robert Rünishin, who is unfortunately sick, but he wishes all of you all the best and hopes that we have an amazing workshop. So that brings me to the first organizer of this session, which is the Digital Public Health section of the German Public Health Association, which was founded in 2022. And we're a network of researchers and practitioners in public health and digitalization, aiming to improve the areas and the knowledge in education, research, and practice in these fields, and facilitate the establishment of networks. If you are a member of the German Public Health Association, please feel free to drop by and let us know if you would like to be added to our amazing group of people. The second organizer is the Early Career Researcher Academy of the Leibniz Science Campus Digital Public Health, which is around already for 4 years now. And we are a group of 40 multidisciplinary researchers, usually and even doing their PhD or just having finished their PhD. And the Early Career Researcher Academy aims to support early career researchers in preparing for their career within and outside academia, through such webinars like the one that we are doing here for skill building, for science communication, and also for establishing networks within and outside the LSC. So what is the topic that we're going to talk about, and what is this digital public health? And why am I talking about this digital public health and not of digital health? Although digital health is the dominating term these days, in my personal opinion, it quite lacks on the various umbrella terms that public health itself is. So as Anna Odone, a colleague of mine, said in 2019, digital public health is not a new discipline itself, but rather the digitalization of methods to achieve the classic public health goals. And as such, with that, we are not targeting individuals in clinical context, but rather vulnerable groups and other groups of the population that goes beyond the clinical healthcare. So as such, we are including digital health for clinical purposes, but also go far beyond that, as you will also see in our presentations. Co-creation, on the other side, is also an umbrella term, which includes co-ideation, design, implementation, and evaluation. And it is a generating ideas for solving problems through a participatory approach, you can say, where we are including target populations in the development and of interventions, as well as in the implementation and evaluation. What we see is that digital public health comes with a variety of challenges where we can apply co-creative approaches as a solution. So for instance, we have low long-term use and high attrition rates in digital interventions when it comes to health. A lot of people maybe download our app, but they lack in staying with our app. And there is also unclear evidence, and it is tricky to address public health and health equity also. So co-creation here can help us to align our intervention with community needs and preferences, so that we're not developing for the development purposes, but developing because the community actually has needs for that. And with that, we are improving the engagement and retention with our intervention and then eventually improve the health-related outcomes. If you want to read more on the topic, I highly suggest these references. And I would now like to introduce to you our speakers. At first, we will have Professor Christiane Stock, who's from the Charité Universitätsmedizin Berlin, who will present the Living Lab approach to develop a virtual reality simulation for adolescent alcohol prevention. Unfortunately, today without Robert Rünichen, but I'm sure he is with us thinking. Then we have Hande Genscher, who used to work at the Leibniz Institute for Prevention Research and Epidemiology and is now at the Robert Koch Institute, who was leading the mGender Pflegebot intervention, which is a bilingual WhatsApp chatbot for mental health promotion for informal caregivers. We then have Maham Salem, who is also working at the Leibniz Institute for Prevention Research and Epidemiology in Bremen, who will present the TAPM Plus app for lay health workers to address common mental health disorders, followed by Professor Kevin Dadaczynski, who is a professor at the University of Applied Sciences in Fulda and the Center of Applied Health Sciences at the Leuphana University in Lüneburg. And he will present the award-winning Nebulus intervention, which was a generic health literacy intervention for the population group's needs. And then our last presentation will be from outside Germany. It actually will come from the University of Zurich, from Dr. Anita Thümeyer and Anna Tietjen, who will talk about patient empowerment in e-learning courses and stakeholder engagement. That being said, I will give the floor now to our first speaker, Christiane Stock.
Yes, hello everybody, and thank you, Laura, for the nice introduction. So I will share my screen and my slides. And I'm happy to share some insights to you from co-design of a virtual reality simulation for alcohol prevention, which is a collaborative project with colleagues from the University of Denmark, of Southern Denmark. So the prototype was developed in Denmark, and I will provide you with some insights on very briefly the background, but the project aims, and then the majority of my talk will focus on the co-creation process and how young people perceived the co-creation process. And then if there is still time, I will also shed light on some user experience data that we collected in Germany. So the background on alcohol prevention in youth is very similar in Denmark than it is in Germany, as you can see here, with the prevalence of heavy episodic drinking being on average much higher in these countries than they are in the European average. And therefore, these the approaches that we strive to establish with virtual reality build on existing evidence on social influence prevention programs on alcohol consumption in this age group. And we are aiming with resistance skills training for adolescents at improving coping skills to cope with high pressure situations, and to developing social skills to refuse alcohol and other drug offers, which is very important, without experiences negative social consequences, which adolescents are actually afraid of. So these kind of programs exist already. They usually work with role play approaches. And we translated these type of role play into the virtual environment. And the project aims were to develop a virtual reality alcohol resistance training tool based on the Living Lab methodology. and to do this in co-production with young people. And therefore, we established a group, a development group together with quite many stakeholders, with experts from the Griffith University, with engineer experts in game development from the technical faculty of the University of Southern Denmark, with drug prevention practitioners from facilities at Danish municipalities, and then also with young people that were enrolled in an adult education course at a Center for Film and Game Production. And then finally, we realized it also with pupils, with students from a boarding school with a focus on theater. So the development group actually consisted of these 4 different parties. And I will focus now very much on the experiences of the 11 young people who actually developed the content of the simulation game, together, of course, with public health researchers, with prevention practitioners, and with game developers. How did the development look like? What were the different phases of the co-creation process? We first started with exploration of key concepts. That was a workshop where we looked at an existing similar product and prototype developed in Australia. And the young people and the practitioners, they decided about how useful this approach is for Denmark, and they created a list of concepts and scenes and recurring themes, and also topics that they wanted to improve in a Danish version. The next phase was a longer phase over several weeks, where the young people developed a film script. We came together to also discuss this script, and then we went into the next phase, which was the prototype design. And the design was actually to develop this virtual reality tool that was by creating the video takes and to compose them into a game engine and to compose them into a simulation game. We entered then the next phase of innovation design, where first in the development group, we looked at the prototype and developed a list of improvement. And then this prototype went into the testing with adolescents, and that the outcome was then a scientific article also on the user experiences. And finally, we evaluated also the entire development process. Just some short words about the app that was developed, both in a Danish version where it is called VR Fest Lab, and in a German version later on where it is called Virtual Limit Lab. It consisted of 128 single scenes as an interactive house party experience where the users can steer their own party, go through different phases, make different decisions on alcohol use, like it is portrayed here on the left side, and they then consequently also made different experiences with different levels of alcohol, but they could also opt for other activities at a party like dancing or flirting options and so forth. And at the end of the game, they received some social feedback as a screen, as portrayed here in a screenshot through a smartphone app. And I would now present some results on how the young people who participated in the co-creation phase perceived the entire co-creation process. So we conducted 9 focused semi-structured interviews with students from the development group. It was 4 female and 5 male participants on 2 different questions. The first question was, how have your ideas been used? And we found overall quite supportive and positive quotes and experiences from the participants, as also demonstrated in these 2 quotes. I will read just the first for you loud. Even the silly ideas I came up with, they were also well received, as long as you kept within the boundaries of what was realistic. There were no wrong answers or wrong ideas. You could only come up with good ideas. I actually think that was really nice, and very similar was also the other quote that I have presented here. We also ask how they experienced the collaboration with the researchers and experts, and the quote here demonstrates here, I thought it was really fun to create these characters, and it has given me a new kind of self-confidence, or what it is called. And there were similar statements from other interviewees that also showed that the participation in this co-creation process also improved their self-confidence, their and was kind of a also empowerment of the participants who participated in this process. There were also some critical aspects from the interviews, and the most stressed fact that was seen critical was that the students could not be involved in the entire process, but only in phase 1 to 3 of the living lab, because their course then ended after 4 months, and the entire production process was longer than that. Also that they were enrolled in a course, and the collaboration was made with the school with which they where they took this course, and so they did not perceive it as fully voluntary. Actually, they were happy to be part of this project, but they felt that they did not really decide for it. We finally also did some user experience testing, and also took a focus on gender-related experience. Just very brief, I'm about to come to an end. That was research that we did in Germany with 13 young people. And we did structured focus group interviews with them on 2 different aspects, on content-related technical assessments and on a gender-related evaluation. Overall, the user experience here with a user experience questionnaire was perceived as overall positive, both in terms of pragmatic quality in orange and hedonic quality in blue, as you can see here from the mean values that were all at the positive end of ratings. And the more qualitative statements, here I show you some themes that came out of the analysis, for instance, on the simulation strategy, how adolescents used this simulation. I played 2 rounds. In the first round, I just strictly said no at every opportunity. And in the second round, I did it the other way around, and the first round was much longer. So we learned a lot about how user actually used the simulation. what they said about the selection of options. There were so many options that you could choose and interact with, and overall the user, the VR expectations, as you can see here from the third quote. On gender related evaluation, we found that the adolescents actually wanted to have more themes in this simulation, not just addressing alcohol, but also addressing alcohol in the context of sexual harassment, as this quote here shows. They did not want necessarily that the game was more tailored, like that you can choose to enter the game with more than 2 avatars as it is present. And but a lot of, or some of the respondents would like to see more non-white people in the game. That means the representation of diversity also should be improved. So overall, in conclusion, the Living Lab approach was useful in structuring and guiding the co-creation process. The students who were involved in the process benefited from the collaboration, which resulted in self-empowerment, increased self-efficacy, and also new skills that they learned. The creativity of the young people was very positive for the development and of the game. The overall development benefited, and the end product was much closer to the youth real life experiences. And we also found from our evaluation that further development of the simulation, both based on this qualitative input from users, is still needed. So thank you very much for your attention.
Thank you very much for your presentation. It was on point also from a time perspective. Does anybody have any direct questions? Otherwise, I would just hand over to Hande for the next presentation. That does not seem to be the case. Then again, the reminder, if you have any questions, feel free to drop them in the chat also while a presentation is given, and we'll make sure that they will be answered after that. Then Hande, the floor is yours.
Thank you. Let me share my screen. Good afternoon from my side too. I'm Hande Genscher. I'm a PhD/guest researcher at BIPS, and currently I'm working at Robert Koch Institute in Berlin. And I want to present the Gender Pflegebot, a bilingual WhatsApp chatbot for mental health promotion for informal caregivers. And informal caregivers or informal caregiving is one part of unpaid care work, meaning unpaid physical, cognitive, emotional labor or services that is provided to family members, to friends, to acquaintances. And informal caregivers look after sick, elderly, chronically ill, for just naming some examples, family members or extended family members and friends and so on. And just to give you a quick context as to why we chose to do this intervention, I have some bullet points here, and mainly it's like due to demographic aging, we can expect more elderly people in the population, and at the same time, we can expect more informal caregivers. So this is a population group that is going to be increasing with time, and currently we have 4.5 million in Germany. And not so unexpectedly, women are more likely to be informal caregivers, and at the same time, they also provide care to a greater extent and more intensively than men. And informal caregiving has also negative impacts both on mental and physical well-being. And women informal caregivers are more likely to be affected by these, especially women with their migration history. And we have done our literature searches, not systematic, but we found that on-site health promotion offers are rarely used, mainly due to time constraints and informal caregivers not being able to find replacements for the care recipients to go somewhere, let alone to go to a health promotion offer. And we also found that digital public health interventions seem quite successful in reaching these population groups, which is why we decided to develop a digital public health intervention for informal caregivers. And we wanted to do this based on three main elements. Firstly, we wanted to co-design this intervention involving both users and stakeholders in different phases of the project. And we wanted to be mindful of the intersection of gender and migration history, and consult both women and men with and without a migration history. We secondly wanted to use existing technologies and those that were already in use in the everyday lives of informal caregivers, and especially those with a migration history. And so we decided to use WhatsApp, for example. And we wanted to install a chatbot into WhatsApp, and we wanted to use a digital storytelling approach to make visible the everyday lives of the users, informal caregivers in this case, and to allow for participation. And lastly, we wanted to use evidence-based behavior change techniques for mental health promotion. Our co-design process, this is in a nutshell, obviously. It was a very huge process, but what we did was basically we did a needs analysis with 27 informal caregivers via personal interviews, asking or exploring their everyday lives, their mental health, caregiver burden, caregiver situation, and also their needs for health promotion. And we had 19 women, 8 men, and 8 persons had a migration history in total. We then, based on this data, we identified the contents, the themes, and also the format of the intervention we were planning. And with this, we prepared this and went into different focus groups with users and stakeholders and received their feedback and created and recycled the final content or the final elements of the intervention. And by recycle, I mean that we also used information or content such as text-based content or video content, which I'm going to present in a bit, that was already provided by official websites, by the health insurance funds, etc., and which we really elaborately translated and sometimes dubbed even and put subtitles on to translate it into Turkish. And then we also had evaluation workshops at the end of this intervention process. One was a German intervention, a German workshop. The other one was a Turkish workshop with both users and stakeholders that were involved in the process. This led us to our Pflegebot. And the Pflegebot consisted of 8 modules, which you see here, consisting of digital storytelling, caregiver support, caregiver training, relaxation techniques, and to your right, you can see political empowerment, community support, behavior change, and FAQs. And these FAQs, you have to imagine like a basic user chatbot interaction via a standardized form. So you could just insert a word into the chat. In this case, it was Frage, question, and then an FAQ list would pop up that was pre-standardized, and people could choose which type of information they wanted to have using this chatbot. And we used ChatFuel as our software provider and WhatsApp as our platform. And we also had human user interaction, which consisted of basically the WhatsApp chat. So the users were possible to chat with us if they had any questions that were outside the FAQ that was already pre-standardized. We tested this Pflegebot intervention in a 12-week feasibility study between September 23 and March 24. And we recruited participants via our cooperation partners, which included caregiver and migrant organizations. We also used social media extensively to recruit them. And we really had like personal visits to lots of care facilities and lots of self-help groups and stuff. And we also used personal context, which was very good in context of reaching Turkish persons with migration history. And what would happen would the participants would receive a QR code, either via a printout leaflet or via social media posts or our website. They could scan the code. They would be forwarded to a link to a pre-survey. And at the end of the survey, they would receive a link to the Pflegebot, and they could install the Pflegebot on their smartphones. So what we did in the pre-survey was to collect data on basic demographics, on mental health outcomes, including depressive symptoms, stress levels, loneliness, caregiver burden, and also like caregiving characteristics. And then they would receive daily messages for 12 weeks. These messages would include text messages, videos, and links. And after these 12 weeks, they would receive a link to a post survey. And additionally to the mental health outcomes, we would also use a usability measure to measure the usability of the Pflegebot. And in total, 104 participants were recruited. So they did the pre-survey and they installed the Pflegebot. At the end, only 48 participants completed the post-survey. So we had quite a high attrition rate, as you can see. And these are basic selected results from the pre-survey. So as you can see, we had the majority of participants were women. 20% had a migration history and 70% had high mental stress levels due to caretaking, which is also quite a signature thing for informal caregivers. They're a very stressed population group, and 60% showed depressive symptoms. And I have like some selected results from the post survey. As you can see, we can see in general quite a decline in all mental health measures, which is good, and a slight increase in caregiver burden. But these results really need to be interpreted with caution because of the sample size. And the usability score was quite high, which is also good. And we also had high levels of satisfaction and acceptance from the participants. And we did have some challenges, which I would like to discuss with you. And I wrote down the major challenges that we faced. And the most important one was the verification process of our WhatsApp business account. So in order to use a chatbot application on WhatsApp, you have to have a verified WhatsApp business account, because if you don't have that, you cannot connect your account with ChatFuel to provide you with a chatbot. So this took quite a long time. It was very complicated. Also being in touch with Meta Business, and we succeeded at the end, but it was a very lengthy process. And while this was happening, there was a rapid change of software regulations, and major updates were made, which required a constant and rapid adjustments to the chatbot. So we have to like do quite a few adjustments daily. And this concerned more the early phases of the chatbot. And the chatbot itself, at the end, we really realized that we had too much content. We created a lot of content ourselves. It was very elaborate and time consuming. We created 26 own video productions. I would not recommend that on a limited budget. And in terms of the participants, it was as you could see, it was a quite small number of participants. We did anticipate 100 participants, which was okay, but at the end it was only half of them that participated in a post survey. So it's very it's not easy to speak about feasibility at this point. It is a hard to reach population group, and what we found out in the evaluation workshops was that a lot of users were quite skeptical of the pre-survey that we conducted, and we thought that it was likely the pre-survey that discouraged the participation. And I think in a scenario where we do not have this research that overshadows the actual usage of this Pflegebot, it would be a higher participation at this point. Before opening the floor to questions, I just wanted to show you how these messages looked like. We had, these were like the recycled messages, or the messages we created using content that was already there, which was also translated into Turkish. Sometimes we had to include subtitles. In some videos, we had to actually dub the videos into Turkish. And these ones are our own productions, examples of our own productions. We interviewed a lot of relevant caregiver support organizations. We made own videos about regarding behavior change techniques. We interviewed or had this digital storytelling approach where we would interview actual informal caregivers about their everyday lives, about their struggles, and we also made animation videos with information around where can I get support and so on. And this was just a snapshot of the FAQ that I was talking about, that enabled the user chatbot interaction. That being said, do you have any questions?
If nobody wants to ask a question, I would have one. Did you, I mean, it's meta, so it was most likely quite problematic. But were you able to analyze the number of clicked content as to with the videos? I saw one was like 1.5 minutes long, the other was nearly 10 minutes long. My personal feeling would be that the shorter the video, the more interaction was there. Did you have any data on that?
We did collect the data on like the clicks that you were talking about, but we had technical problems with ChatFuel, so we were not able to represent the clicks, and which is which is really bad, because we wanted to also evaluate the usage of the videos to have a feeling for, okay, what is something that is more accepted by the users, what is something that is not watched at all. So at this point we cannot make any assumptions or do not have any results on that, which is also very bad.
Thank you very much for the interesting presentation. I was wondering why these videos were sent individually via chatbot and not on a broader scale, like via social media and stuff, because I personally think you would have a lot of viewers, especially individuals who might want to look at these in a broader scale. And then your work would actually be honored and people would actually click on them to just get in like a motivation for the day. I think this would be really nice. And you already did like a lot of work in there. Like you already did a lot of videos and content. And I personally think it should not be limited to like really seclusive space. If you can, if it's not drawn into individuals and stuff, and they are kind of confirmed that you can use that as a purpose, I think this is a really great project.
Thank you. This is actually something that's happening now. We decided to not share the content on social media. We have a Instagram account, and we wanted to use it in this in the context of this intervention first, and then we are trying to now upload the content on our website. And also with limited resources, the project ended in March, at the end of March. So we have to see how we can gather new resources to continue with this intervention, to continue with this project. But this is something that we're planning to do. So we put a lot of work into the videos. Yes.
Yeah, thank you.
Thank you for your feedback.
Okay, then if there is no more question, then I would give the floor to Maham to bring us to Pakistan.
Yes, hi everyone. Thank you, Laura. I would now share my screen. Yeah, and hopefully you can see my screen in presenter mode.
We can.
Yeah. Okay, perfect. So I would be talking about Technology-Assisted Problem Management Plus, which is a co-produced digital app for lay health workers to address common mental health disorders in Pakistan. This was produced as a part of Project Well Park, which was a collaboration between BIPS, a University of Ulm in Germany, and Health Information System Program in Pakistan and Fazaya Medical College in Pakistan. A little bit introduction about Pakistan. Pakistan is a middle income country in South Asia with the prevalence of common mental health disorders almost 34%. The mental health services are only available in tertiary care hospitals, and there is a treatment gap of mental health disorders in low middle income countries, approximately about 75 to 99%. Along with that, there is also stigma, cultural taboo, lack of resources, and out-of-pocket expenditure for health. So, according to World Mental Health Atlas, there were only 375 psychiatrists in 2019 in Pakistan, and Pakistan is a country with a population of 250 million. So you can imagine how low human resources for mental health is there. And this is the current mental health care in Pakistan. So there is a community that has access to primary health care only, and there is no mental health service at the primary health care. There is stigma, there is lack of resources. Also, sometimes these disorders go unrecognized, and maybe one person out of this community would go to a big city in a tertiary care setting to seek help for mental health disorders. So that's why there is a treatment gap of 75 to 90% in most of the low and middle income countries. So there are global strategies for reducing the mental health burden in low middle income countries like Pakistan. WHO has produced a MH Gap Intervention Guide, which consists of evidence-based interventions for common mental health disorders. This guide also advocates for task shifting, which means that these services for mental health disorders should be given through by training lay health workers and non-specialists. And also more recently, WHO has developed the Global Digital Health Strategy that also advocates the use of digital technologies for increasing the access in countries like Pakistan. Out of the from the MH Gap Intervention Guide, there is a intervention known as Problem Management Plus, which is a brief psychological intervention, and it targets the symptoms of anxiety and depression, and has the same and uses the established techniques of problem management, behavioral activation, and relaxation techniques. Has an inbuilt benchmarking and monitoring mechanism. Has been culturally adapted and also translated to Urdu. Has been rigorously evaluated in Pakistan and proven effective. So from combining all these things, we basically had an aim in Well Park project to co-produce a technology-assisted problem management plus for lay health workers to use efficiently, delivering sessions to women within the community settings of Pakistan. We use Hawkins' three-stage framework of co-production of public health interventions, which consist of three phases. The first phase is evidence review and stakeholder consultation, in which the current evidence is reviewed. There is multiple informal consultations conducted and also formal in-depth interviews. Then we formulated an intervention development group that basically took the feedback from the phase one, developed the intervention, refined it, and then this is progressed into prototyping, where the expert reviews your intervention and also testing is conducted. I won't go into details of this, but we did a quick literature review of Problem Management Plus and explored how it is adapted and implemented in low resource settings like South Asia. Then we conducted qualitative interviews with the major aim to identify TAPM plus functionalities. We conducted 3 focus group discussions with 32 lay health workers. Then we had semi-structured in-depth interviews with 9 people from health system and also from policy level in Pakistan. And basically, okay, yeah, sorry. So the main aim was to identify the barriers that we would the barriers and facilitators to implement technology-assisted problem management plus, and also to identify app functions that could basically facilitate the implementation. So just looking at the app functionalities, they were like promote enablement. The app should be easy to use, it should have user guidance, it should be time efficient, it should increase the digital mental health literacy, it should be persuasive and destigmatizing, it should promote patient engagement, it should have offline functionality, and it should also have online support for the lay health workers. Taking all these themes, we then had our co-production meetings with 10 members, and they were software developers, clinical psychiatrists, epidemiologists, public health researchers, and health system researchers, both from Pakistan and also global. We had 8 co-production meetings, and one meeting lasted 120 to 150 minutes. And along with that, there were also multiple informal consultations with the local and global experts. So this is what we did. We basically took the themes, and from those themes, we developed the features. So I won't go into detail of all, but for example, for user guidance, we developed features like the TAPM Plus should have prompts and alert guiding the lay health workers. Also, there should be instructional manual how to use the app. For the cognitive load of lay health workers should be reduced, and all the questionnaires should be automated. There shouldn't be any typing, but there should be, we should enable audio recording. The app shouldn't depend on internet, and there should be an online supervision. Also, for destigmatization, we had videos for the patients, and they were narrated by a female doctor, so that it's in a very destigmatized language. And also for added persuasion, we chose a female doctor. Then the third phase was prototyping. We conducted 2 rounds of usability testing with 6 lady health workers. These lady health workers were first trained, and in the first round, it was conducted in a lab setting, and in the second, it was conducted in a field with 6 depressed women from the community. And then we basically used the questionnaire, MOAC questionnaire, which is an mHealth app usability questionnaire with a total range of scores from 0 to 7. And our scores range from 5.62 to 5.84, which shows high usability of the app. This is some of the interface of the app. Just to add on here, this app was developed for lay health workers to help her in the delivery of the sessions of the Problem Management Plus intervention. So this is what we did. So here, basically what we have lay health workers that deliver services in the community. We train those lay health workers, we give them digital tablets and installed our app on this. They went in the community, they delivered the 5 sessions of Problem Management Plus, and through an inbuilt monitoring mechanism, if anyone condition was getting worse, they were basically referred through the primary healthcare system into the tertiary healthcare system. Some of the key consideration and also some of the challenges that we faced while developing this is that funding and timeline. I think it's very important to break the development of digital intervention into alpha, beta, and final versions for different, and keep it for different phases of your project. because it's very difficult to incorporate feedback within the timeline of one project. Because at the end of the day, it's a digital intervention, and it's not something that you receive a feedback and you say, oh no, okay, we will just train the lady health workers for 5 days, not for 6 days. So basically it's a software that needs to be changed, and that requires a lot of funding and also time. Also, during the co-production process, it's very important to be very flexible and open, and also plan according to the context and resources. We started the WellPark project with the aim initially to make an app for the layperson, for anyone with a mental health disorder. But then we realized that this would never reach the public, and it's more, and then we basically developed something for lay health workers, because they have access to the community and they deliver services to the community. Also, it's extremely important to be mindful of the power dynamics in the co-production groups. We never had lady health workers, lady health supervisors, and also people from policy and health system in the same group, because it doesn't give the true, I would say, variation of ideas. Also, accept any level of engagement from stakeholders. You cannot expect somebody from policy or someone from health system to be there in all the co-production workshop with you. But look for creative solution, interview them, go back to them, or maybe an informal phone call is sometimes enough to get the feedback that you require. Also, for digital intervention, it's extremely important to co-produce the intervention, conduct the usability testing with those stakeholders in a lab setting, and then it's very important to co-evaluate, because that's where in the co-evaluation is where you receive the main feedback. And that, again, I would go back to my first point, that once you do that, then maybe you can refine your alpha version into a beta version, and then go through the same process, and then you would have the final version. Yeah, that's all.
Thank you very much, Maham. Does anybody have any direct questions? I also do not see any in the chat. Then I would have a question. How was the digital literacy within your target population? Did you encounter any problems with that? And if so, how did you recognize and consider that in the development of the app?
So yes, the digital literacy of the target population, that is the lay health worker, also known as lady health workers in Pakistan, because that cadre is women only, is very low, because these women are not specialists. Their basic education is 10 to 12 years. And we were very mindful of this when developing the app, and certain features of the app was planned just to target the digital health literacy. For example, we had 2-minute refresher videos for all the sessions, which basically guided the lady health worker in 2 minutes where they have to click in the app and do what step of the intervention. Similarly, all the sessions had consistent feedback. There was no typing. The app was fully automated. It would basically guide a lady health worker from one step to another. There was also a personal dashboard for her, where she would just click on the patient and it was all automated. She would just go on the session that she needs to deliver. So yeah, a lot of things were planned just to help them with this.
Cool. Thank you. Anybody else having any questions? Then I would give the floor to Kevin once he's okay.
Thank you so much. Hi from me. Pleasure to be with you today. First of all, as you could see, I'm a little cold. I have a little cold, so apologies if I have to coughing or sniffling, whatever. So please apologize that behavior. So I share my screen, and Hope you can see it in a second. Ah, that's okay. Okay. I hope you can see. Can you see the presentation mode? Does it work for you?
We can see your presenter mode.
The
right now.
presenter mode. Then I have two screens here, so that mostly happens. Better right now?
Yes.
Perfect, perfect. So I would like to talk a little bit about our nebulous intervention, which tries to strengthen health literacy. It's a digital game-based intervention. And before I want to talk about participation, co-creation, I want to give you some basics about the intervention. So obviously it's about health literacy. And as you might know, health literacy is focused on motivation, competencies, and knowledge that is necessary to find health information, to understand health information, to assess health information, and to use health information in everyday contexts. So when we look at the empirical basis, at least for Germany, we see that more than half of the adult German population show limited health literacy, which means that more than half of the German adult population has substantial problems in finding, using health information. And if we look at another population group, the young people, these are the most current data from the HBC study. We see that 25%, around 25%, have a low health literacy, which means very low health literacy. So obviously, we really have a need, a public health need here, and we need to strengthen health literacy. We, in the intervention nebulous, looked at the very specific part of health literacy and a very specific concept of health literacy, which is navigation health literacy. So in here you see an adapted definition adapted by Grieser and colleagues to the local context. And we say that navigation health literacy is the ability and motivation to find, understand, evaluate health information in relation to related to health services provided in or by organizations or health professionals in a person's vicinity, which means that people do not only look for information in printed information sources or digital information sources, they get the information in their direct living context from, for example, youth councils, sport clubs, whatever is in your direct vicinity. And that would mean that people need the ability to find local organizations that can offer support in various health topics. They need to understand these information provided by health organizations, but also the health services. They need to evaluate these information, and they also need to evaluate whether a specific health services and their provisions fit with their personal health needs, and they need to apply these information that they have received. So this is what we call navigation health literacy, and this is in the core of our intervention nebulous. The intervention nebulous, in a nutshell, is composed of three parts, main parts. The first part is the so-called nebulous planning tool. The planning tool is a browser-based tool which allows local stakeholders or setting responsible persons to create their own tailor-based scavenger hunt on health-related topics. Could be every topic from mental health, nutrition, physical activity, whatever is necessary or important for the local health services. And they can create those kind of scavenger hunt. And a scavenger hunt, as you know, is kind of exploration rally where people can get in contact with their local health services in a playful way. So they can create these scavenger hunts using the nebulous planning tool. And we have on the other side, oh, there's missing an N, we have the nebulous app. And the nebulous app is used to run these kind of scavenger hunts by the users themselves, young people, whoever uses the nebulous app. And we use it at the moment for different population groups. We started with young people, older children, and especially adolescents, but at the moment this app is used by so many population groups. I will come back to that in a minute. And the third stumbling block is the nebulous communication material that we have. And we have used various tools for communication. We have, of course, web page, of course, but social media, YouTube, we have a help center, manuals, all kinds of stuff which help the local stakeholders and setting responsible people and organization to use Nebulous. Okay, to give you some screenshots, here you can see the Nebulous app. The Nebulous app comes as a kind of location-based game. It's a location-based game approach, as you can see here on the middle screen. Once you have added the code, then the app downloads the specific scavenger hunt. And as you can see it here, you can see my mouse, as you can see it here, different stations will pop up. And if you click on this, you will find information how to get to the station, what the station can offer. And it's not simply the station pops up, go to the station and find information. This is not the case. But what we try to do is to embed all this in the entertainment education approach, which means that we want to achieve a kind of immersion through providing a fictional story that is told from the perspective of young characters through, for example, voice messages. Just to give you an example, one of our best used stories or scavenger hunts is that a certain person disappeared and her best friend tries to find this person. And he asked the players, the users, to help him or her to find the person who has disappeared. So this is delivered via voice messages, and then this person, the helping hand in a way, says, please go to station A, B, C to find information. And behind each station, there is a local health service, sports club, whatever is necessary. And they go to these stations to get some hints, some tips. And in a low threshold way, they get also information about what the service offers. So they get health information, they get information how to address the health service, etc. So as already told, we use a number of game elements. It's not that we use competitive game elements, so it's not about that. It's more about exploration. So we use gender and culturally sensitive avatars. We use an interactive map. We use a story. We have stations that you can see here on this map, but we use also hidden stations which can be explored. We don't use points and all those kind of things, but we use badges as a typical game reward. So, and on the other side, we have the Nebulous planning tool that you can see here. I forgot to say that the app is available on German language, English language, and on Turkish language at the moment, and the planning tool is available on German and English. So it can be used from everywhere, from all countries. It's free to use worldwide. The planning tool, as already said, allows us to create these scavenger hunts by the local professionals. It could be everyone. It could be a school, it could be a university, it could be a health club or a sport club, it could be a counseling service on a local level. So there's no limit on that. You don't need any specific IT knowledge. Scavenger hunts can be easily created by running through 5 steps, adding information, uploading images or audio files, etc. So we support that, as already said, by videos, manuals, and sample scavenger hunts, which can be imported and adapted to the personal needs. So this is Nebulous, and now let's go to co-creation. Co-creation, I give you a very nutshell. So we did a lot of that, and just a brief summary of the things that we did. First of all, while today we focus on co-creation, you all know that there are so many words out there which capture similar things and similar concepts, which have their own notions. Participation, user involvement, today about co-creation, could be also about citizen science. And we have many terms, but all are concerned in one way or another with users giving a say. And this could be that these approaches aims to generate ideas that are relevant and meaningful to people in one way or another, and also by inviting them to collaborate in all phases of research. That would be maybe more citizen science, but it could be also in the development of any innovation. And this is the case for Nebulous, that we invited them to be part of innovation development. And the rationale behind all this is, as we all know, and Laura said that at the beginning, is that involvement increases ownership and empowerment and facilitates the development of tailored and especially effective approaches. This is the rationale that you always have in mind, although there's also some evidence which is a little bit contradicting. There's also evidence saying that this is not necessarily the case. But I think you all know that. So the methodological basis for that are twofold. The first one is very similar to what Christiana has already introduced in her presentation. It's the living lab approach. And we use the living lab approach as a kind of real life experimental environment where not only users, but also producers work together to come up with a new innovation. So we're oriented towards this, as you can see it here, towards this continuous development cycle. We focus not only on users, and for us, our, let's say, first level beneficiaries are, for example, the adolescents, but we have also secondary level or second level beneficiaries, which are the local health services, which use the app as well. We have a number of stakeholders here in this story, and this is very important. We are not doing it in a kind of laboratory environment. We are doing it in a real life environment when we develop new solutions. So real life, not real life. So, and the second thing that we focused on, and I'm pretty sure you all know that, we have different typologies of participation. And this is just one of them, which I really like, comes from Harris and colleagues. It's based on a review, and they distinguish more than these three, but at least these three, and this is consultant, collaborator, and driver. Consultant, as you all know, is just in a kind of informant perspective. People were asked to hand in their feedback, they were asked as an informant, but that's all. And the decision is being taken by the professionals. And then we have the collaborator role, which gives the user more responsibility as they are involved in co-production process and a little bit decision making. And of course, as we all know, the driver would be that we as the researchers will be invited if necessary. So all of this would be driven by users, the whole developmental process. But it's we have not reached this level of participation in Nebulous. When we talk about us, who is us? It's of course we as the research team at Fulda University of Applied Sciences. We are really intersectional research team coming from different fields of public health. We work with various IT experts, as you all did, with user experience designer, web developer, storyteller, and various other experts. The user, and of course, as I said, we have the adolescents, we have the first level beneficiaries in a way. They should have the most benefits by using the app. This were adolescents, but also older people. We have an ongoing, very great collaboration with Kempten University of Applied Science, and we try to adapt Nebulous to older people at the moment. And we have these public health practitioners on a regional level, on a local level, on a national level, who should use this app. Okay, and this is my only 2 slides to go. A very brief overview of what we did. You see here 3 phases, which also comes from the lab approach. We have the exploitation, which would be a kind of ideation phase. Then we have the experimentation, which can be translated with a kind of development phase, and evaluation is not here as a separate stage, as we try to do it in a very iterative way, which means that development, evaluation, and redevelopment took place in one, not in the same process, but is very close to each other. So just to give you some snippets here, with adolescents, we had a kind of ideation phase where we asked in several workshops, we had a fixed group of adolescents, which we invited again and again to come up with mental maps of their health services they are aware of in their locality. And we discussed potential services and barriers of utilization. Based on that, we organized another workshop with a game creator, and we just closed the door. We were not part of that workshop where they tried to come up with game stories, with characters, which might be good to address these barriers. So then we went over to our user experience designer, web developer, and gave them the result of the workshop and tried to develop with them the first concept, the first designs, the first mock-ups, etc. And this were then handed back to the adolescents to be discussed in other workshops. We had individual walks, we had user experience, lab research design, and this all took place during COVID-19 2020. So as you can imagine, there were not much space for exchange. This was a great limitation. So we had a kind of board with local and regional stakeholders where we tried to meet regularly online based due to COVID-19, where we developed scenarios how they can use Nebulous in their daily routine and what would it take them to use Nebulous in their daily routine. But as you can see, this is not a driver-led approach. This would be a maximum of consultant and collaborator approach. This is important to know. And when I look at the presentation we had so far, a lot of them is consultant and collaboration approach. It's not driver, but a driver-led approach is quite difficult to achieve. And it has a lot of prerequisites to consider. So I just have some reflections on that. What we tried to do, we have not done the best approach in the best way, to be very honest. We wanted to have more. COVID came, so we had to deal with the limitation that we have. But what we tried to do is not just to focus on the first level beneficiaries, the users, the end users. We tried to include all of them who were part of the whole developmental process. Also the designers and web developers. This is very important to know because we are also trying to find a balance because we commission other people to come up with work or to come up with a product. So what you do is to do a contract with someone and then you ask for a product and to give them the power and the balance to come up with their own suggestions, someone who you pay for. This is something that we really learned in this process. So we had some really great problems in recruiting, especially young people. It's hard to motivate them to join such a journey, a participation journey, especially, of course, due to COVID-19. And it's also difficult to deal with out-of-the-box ideas. I found somewhat the same with Christiana when she showed her quotes. So when, for example, we had an adolescent who came up with the idea we need to integrate a wizard. That was a little bit difficult for us to deal with these out-of-the-box ideas. What, a wizard? How can you integrate such an idea? So this is another learning that we had. As already said, we were not able to deliver a driver-led approach. But what we were able is to not only go for consultant, but also to try to implement a collaboration approach by giving them the opportunity to develop at least pieces of the intervention and having some say in that. And when we wanted to implement advanced forms of participation, this is nothing that you can, as I already said, that you can do by just a snippet. This is really hard to do. We have a lot of prerequisites to do those kinds of approaches. I've not talked about that very much, but another challenge occurs when we have a fixed nebulous system and then we wanted to adapt that to other population groups, for example, older people. And this is something that is also, it's not difficult, but you have in mind that you have now a fixed approach and very limited room to develop things again from scratch. So we need to deal with what you have and we need to adapt it to other population groups. Yes, sorry for being much over the time. Thank you. So if you're interested in using Nebulous for research, practice, whatever, please feel free and get in contact with me.
Thank you, Kevin. And congratulations on keeping your voice together, even though you have a cold.
Yeah, thanks.
For time purposes, I would propose to move all the questions relating to Kevin's presentation to the overall discussion and to give Anita and Anna all the time that they need for their presentation.
Thank you so much, Laura. I will share my screen. One moment. I hope you can see it right now.
We can see your screen, so the presenter mode right now.
Yes, perfect. It's on the presenter mode one. Moment. Should be fine right now, right?
Yes, thank you.
Awesome. So hello from Zurich. And we're excited to share our insights from stakeholder engagement in our digital health project, which was an e-learning project. And we will now soonish conduct a randomized controlled trial to evaluate the efficacy of our e-learning project. With our project, we target people with cancer. It is estimated that 50 to 70% of people with cancer have cancer-related fatigue or sleep problems. And since we are from the Institute of Integrative and Complementary Medicine, we are interested if acupressure or mindfulness could help to relieve fatigue or sleep problems. It is recommended in clinical practice guidelines, in the German one as well as in the American one. At the moment, it is mostly delivered by health professionals within a face-to-face setting. And now with our project, we aim to move it to a digital setting to provide them a digital training how to apply such self-care techniques, acupressure and mindfulness. This digital training will be the intervention for our randomized controlled trial. And we would like to evaluate whether acupressure and mindfulness is effective to target sleep problems and fatigue in these cancer patients. An e-learning program offers several advantages, such as standardized instructions, and it's really scalable to a high number of patients.
This project was planned as an implementation science project. Hello from Zurich, also from my side. And in this round, I think I don't need to explain what it is. Within all the research project, we had in mind the patients, the final group, the final target group. And one key strategy to do so is to involve the stakeholder in the co-creation process. And one of our stakeholder groups were obviously the patients, the cancer patients, but there were more stakeholders, for example, the oncology physician with their expertise, then experts on those techniques that Anna mentioned, like mindfulness and acupressure. We also involved other health professionals, also due to the time constraints that the physicians have. So we just needed to widen those stakeholder groups to other health professionals like oncology nurses who are also very experienced in dealing with the patients and knowing their problems. And since this is a teaching project, we are teaching the patients online to these techniques. We also involve teaching experts. Representatives from all the stakeholder groups were integrated into a stakeholder advisory board, and this stakeholder advisory board supported us in all important decisions for that randomized controlled trial. And then stepwise, we consulted the other stakeholders to benefit from the knowledge. We want to show you with two examples how we did this. The first example is in the development of that e-learning course, in the development of the intervention for the trial. When you develop an e-learning course, there are several steps. We started by doing focus groups with health professionals, with oncology physicians, and exploring their expertise and their experience in teaching patients face-to-face those techniques. So we asked them, what are the main barriers of the patients? What is easy to learn? What is difficult to learn? Which information do they really need to understand the techniques? And what are the main barriers? With these, we arrived with key topics, which we explored in consensus workshops with experts on those techniques. So we asked them for their advice. Then we had the content, but in an e-learning course, you can put content in different formats. This we explored with the teaching experts. And here we came up with the e-learning course, with the respective e-learning course, which we tested. Oh, I'm sorry, I'm having a bleeding nose in this exciting workshop. I'm sorry. Okay, it's gone. We had the final course. No, we didn't have the final course. We had an e-learning course, which we tested in several rounds online. Something that we saw also in the previous presentations. It was an iterative process. So we had a pilot course. We tested it with health professionals and patients. We improved due to the feedback that we gained by online questionnaires, and improved further. And after several rounds, we came up with the final course. What was important for us is that, and that's also like an important barrier that we met. I mean, all those stakeholders, they are limited mostly in terms of times, but also maybe in terms of passion for that project. And so we tried really to include those stakeholders when it was most important to have this opinion. Just as an example, we only asked the patients about navigation in the e-learning course, because that would there it matters. It was not. It was less important if the health professionals can deal with the navigation in the e-learning course. It was more important that the patients can do so. And online questionnaires were also very good tools to have experience, to collect experience. But we really learned more when we deepened that in focus groups, which we did with patients after they went through the e-learning course, just as an example. And now I think we are already with the final results of the course. Yeah, I think, these are our test results, and these are only some selected results that show that we came up with a course that is with the relevant content. The content is understandable, and the most important learning objective is also reached. The patients can really apply the self-care techniques independently after the course without even seeing an instructor personally, which is important because most of them don't have access to instructors. And also for the patients, I show you some of the qualitative feedback on the left side. We have mainly the positive feedbacks, which is of course very nice to get some supportive feedbacks from the target group. But actually, where we learned most was of course from the negative feedback, that we could deepen in such structured interviews.
The second example of stakeholder engagement in our project I would like to present, it's a development of the dissemination material for this RCT. Our aim is to communicate effectively and tailored to the patients or to our target group, and that our dissemination material resonates with the patients, that the patient would like to engage with our e-learning course. That's why we took a stepwise approach also of co-creation for this dissemination material. First, one researcher performed a literature research to figure out the motives to participate for patients. These motives we took and used them in order to find how these motives can be integrated in our outreach strategy. After this, we performed a second workshop on message framing. So really clearly figure out what would we like to say, how would we want to address the patient? Should we say patients? Yeah, so we really put out clear messages. This was all performed within an interprofessional research team. We had persons with a marketing background and also like psychologists. It was really important to have like a really nice discussion. And even more, what I would always recommend is like using design thinking methods, like having one as a workshop really good prepared, and that this design thinking methods can greatly facilitate structure and enrich your discussion within this team. When we finished the development or kind of almost finished the dissemination material, we went with our flyer layout to patients because we wanted to have an impression how they receive our layout. And we, at the first two steps, the patient survey and the patient interviews and the health professional interviews, we only asked them about the layout. As Anita mentioned, the time constraints, it's always good to just make a statement, like maybe ask for one thing and not for all of them, because like in the last step we took like some other patient and asked for the comprehensibility of the messages and whether the words are understandable and whether it resonates with what they would expect from the e-learning course. So we went into this public event with 3 different flyers and asked them whether they like them or not, and to rate them on a scale from 0 to 10. And the middle one with a person in the center of the flyer won, which was really nice to know, okay, the people or the patients do like a human on a flyer. But we learned from the interviews, not everyone likes blue hair. And this is what we took and with us for sure. And also it was really difficult for us, like one barrier I would like to mention here, to find a compromise, because our target population is 18 plus, so it can be like a older man, a patient within our trial, or like a young woman. So there's a big difference, and what they like, it's always a little bit subjective, and it's really difficult for us to find a compromise. But we somehow managed. And we ended up with a guidebook which has clear messages for us. We do have now like a brand design, a logo, and a flyer we can advertise our RCT with, and some visuals for the social media post. I would like to give you an impression of our guidebook. This includes everything what we like, our color palette and our logo. And what is really helpful for us is that we have a clear wording, or like what should always be included in external communications, that we do not forget something to mention. And then also we clearly state what can be included but must be included, and what should be for sure avoided. And we are always looking at this guidebook. It's really helpful. And finally, we also came up with our website. And now you can see the woman with blue hair is not there anymore. Now it's a patient with a headscarf. And because we got the feedback from the patients that they would like to see that it's for cancer patients. So they were like, yes, we would like to see a person with a headband maybe. And also like make clear that it's like a digital intervention, because it's
I see a question from Hande. Thank you very much, the two of you, for your presentation.
Thank you very much. I was very impressed by all your like very detailed approach to all of this, and I wanted to ask you about your guidebook. How did you come up with the idea? What would you reference to have a guidebook? Because we had like something similar loosely, but the idea of having an actual guidebook where you set all the definitions, all the wording, and all this is very new to me, and it's very exciting to see this.
Maybe I can add to that. It's coming from the experience from previous projects that you always, once you start to do outreach, you always have the same problems. You have to discuss what to say, what to mention, what to not forget, what not to say. And from our previous project, we saw here something where we could save really time, and we saw a guidebook in an mHealth app that was developed in another working group from our from the institute director, and that's basically where the idea came from. And then we clearly, very quickly, it was clear it was not just about phrasing things. It was also about putting colors, choosing a style. How do we want to communicate? What could be appealing to the patients? And this is something where a lot of opinions were around, and finally everybody is happy with the results. But it was a long way to go. But I truly think it is really worth this work, because that's something that now is really often in use and will be often used during the recruitment of the trial. Yeah.
Thank you for sharing.
Thank you first for the presentation. I really like the project. I was wondering if this product is then marketized, because I honestly think a lot of cancer patients might profit from this idea. And if it's just like available in the small setting at the moment, and if you want to hit the market with it, because I think there's a lot of potential for a lot of people to just be able to do these exercises by themselves. I mean, yeah.
Yeah, that would be the final aim. But of course, before, I mean, it's not a very small setting, I have to say. Now the development phase that took maybe 2 years to arrive where we are. This was a very small setting, but now with the trial, it will open to, Anna, please correct me, around 600 patients. We have to include into the trial, right, Anna? 600 patients.
Correct.
Around, and okay, and then of course, the idea would be that if we can show in the trial that it's efficient to learn it in this way, because we already know the techniques are efficient to reduce the symptoms, but we don't know about the if it's efficient also if you learn it online. And then if that would be the case, that would be great. That would be the main goal, to make it available. Yeah.
Thank you.
But still some time to go. But if you have access to patients, we are really happy to include you in our distribution list. Just write an email to Anna. She will be happy to meet you.
Okay, thank you all very much. There was also a congratulations to all of you in the chat from Claudia Kinnerland. I could not agree more. But this brings me already to my next big question, to kick off the discussion. And I have warned you all that some questions are coming from my side. So I hope you had some time to think about this. But what would you describe and define as the one or maybe even two biggest challenges that you encountered when implementing co-creative approaches in your ideas and in your projects? And you have maximum 1 minute to answer per person, so to make things even more stressful. Who would like to start?
I can start if you guys are okay, because I already talked about my main challenges in the project, but one thing was what I forgot was the level of being like, or the dimension of cultural sensitivity, and not just being culturally sensitive in a technical sense, but also aware that there's like different living realities behind people from different cultures, and culture can also mean like socioeconomic backgrounds, educational backgrounds, and migrant backgrounds, and so even though like I felt I was part of a Turkish diaspora in Germany, I had to realize that there's like so many different more factors at the intersection to migrant history that I was not aware of as a person that would describe herself as part of the diaspora. So I think that was a challenge for me to reflect on this, and to come to the realization that I had to reflect on this to change my methods.
Yes, please go ahead, Christiane.
Yeah, I think in my project, one of the limitations were that the young people were part of this co-creation group, they had a limited time frame in which they could participate. So there were some formalities in a way and some restrictions in terms of the timeline and the time that people could be engaged in the project, which, yeah, kind of limited then, since it was a project that was developed over an entire year, the participation in all phases of the project. So that was one, of course, one limitation. And the other was I think that is a more principal thing in the co-creation or participatory research as such, is finding the balance between the freedom of creation and also the preventive aims of the then final product you want to develop. I would not say it was really too difficult, but it was a discussion then, of course, in the development group about the freedom of thoughts of the young people for what they would like to see as a fun kind of game, and then also the theoretical impact, also based on the behavior change wheel, on what we wanted to see in the game to be portrayed.
Yeah, thank you. 3 hands just got up, but I think Anita, you were the first one. You're still muted.
I couldn't agree more to what Christiane just said. It's really the time constraint that the people have, and it's also like it's a balance to not exploit the people, right? To give also something back. So what we did here is, for example, the health professionals, we integrated it in a bigger course, and it was helpful for them also to learn, for example, acupressure, to teach it on their own to their patients. So we gave it we included it integrated it in a bigger course, and it was part of a certificate that they got. Or for the patients, it was also precious to learn those techniques. So it's something that you always have to consider, that it's also a fair, that you also give something back to the people, apart from that they can create an intervention. Yeah.
I totally agree. Maham, what do you would like to add?
Yes, for me also the issue of project timelines and funding, because so basically we got a lot of feedback in the usability testing that was conducted in the field with the real woman. And after that, we also had to complete our pilot study within that year, and we couldn't include all the feedback that we got into the app because of the time constraints. So if I go back now, I would just basically exclude the pilot study from that timeline and just develop the app. That's why I say that it should be developed in phases and not just one final version.
Yeah. I think, Kevin, that links very well to what you are going to say, I would assume.
That's so true. I could not agree more with what you all have said. So I think I always struggle a little bit with finding the right balance in so many issues. So one of the balances is what Maham just said, because you apply for funding, and when you apply for funding, you have to define very clearly what the work packages are, what the deliverables are. And when you decide to go for co-creation, that would mean to have a lot of openness. So which means that you have to also to deal with the results, and which might lead to deviations from what you have applied for at the beginning. So which means that funders need also to have this openness also with regard to budgets. When you need more budget, you need to cut it from somewhere to put it to another area. So this is something where we have to find some balance. And the other balance that I have found very difficult to find is to not give the users the feeling of being instrumentalized when they're, of course, we all want to give the highest level of or provide the highest level of participation, but sometimes it's quite okay to just ask for feedback. And then this would be quite easy. Also, what I've learned is to communicate about that it would be okay to just ask for feedback. And when they just hand in more than feedback, for example, if they are part of a co-creation process, and if you are not able to implement their ideas, is also about communication, to be very clear, to not give them the feeling that they come up with something and that you do not work with their ideas in a way. So it's always about finding the right balance, I think.
I totally agree. We have a couple of questions in the chat already from Fortress Aku, and again to everybody else, if you have some questions that you would like to discuss them, please either unmute yourself or just type them in the chat, and I'll make sure to get them out there. So the first question here is looking at the ethical issues and whether or not consent from participants is sought at the co-creation stage for their involvement before the actual implementation phase of the idea that was co-created. And another follow-up question was on what informs the number of stakeholders involved at the co-creation design stage, and whether or not you have any guidance on sample sizes.
I think I will just start because no one was talking. But thank you for the question. I have difficulties understanding the first one, but we did at every stage of direct involvement of the participants, be it users or stakeholders, that involved recordings or like the collection of personal data. We always sought or received written consent of the participants. And as to your second question, we did make stakeholder mapping. So we reached out to all relevant stakeholders, and then they would suggest stakeholders, etc. And this was at one point, I mean, in Bremen, the intervention took place in Bremen. It's a relatively small, big city, and it was easy to, I think, identify the important stakeholders. And yeah, this was our approach. We did not have a set sample size for that.
Okay, the next one was Christiane.
Yeah, I also wanted to comment on this, and a consent, written consent is of course important. When ideas are used, or when in these parts where maybe also research activities take place. And the second, actually we also had these consents right in the beginning of the process about, for all the stages that actually followed. And the second, I don't think that there is a real answer to it, because the number of stakeholders depends very much on the type of digital intervention that is to be developed, and how it is then later on being planned to be rolled out or implemented in practice. And who is then involved in implementing it later on, and how many different actors that would be. But I also would, from my personal experience, I would not create a development group that is too big, because it is very essential that you have people in the development group that are also actively engaged and can oversee kind of a development, and not just jump in and out. And I think if you have too many stakeholder groups, it might be difficult to actually manage such a big group and to really actively involve them.
Maham, I also saw your hand Grace, do you want to add anything?
Um, I just wanted to add that yes, it's just, you know, your stakeholders. You can just do the purposive sampling and just select the relevant people you think are important, the target audience, the infrastructure through which you are developing. And for your intervention development, I also agree with Christiana that it's not wise to have a very big team because you need very active engagement. But it's also very good to have a multidisciplinary team with different expertise so that each one can guide, you know, during the development. And it's extremely important to have, for digital interventions, it's extremely important to have any software designer or developers who are also patient enough to be with the research methodology and to go through the process and to guide you. This is something very important. You need to have such persons on team because a lot of software developers out there, they just ask you that give us one fixed idea, we will develop it, you test it, and you know, if there are any glitches in the software, you tell us and we refine it. But they are not very open to actually going through the process and, you know, changing the software over time as per the need of the process.
Yeah, maybe a follow-up question on that. So for instance, the RCT project that Anita and Anna are currently planning, you've decided to involve quite a number of different stakeholders in creating your booklet, and also quite a number of different methods. Did you find any that was more suitable for your approach, or a one that did not work at all that you thought might have worked?
There's not one method. I think it's really, it depends a lot on what you want to explore and how you want to design your co-creation process. So there are points when you need a general understanding of many people. Then of course online surveys are much better than individual interviews, but to get a more deeper understanding, like when Anna, for example, went with the flyers to the patients and she really talked with them in interviews, then you get a much better understanding of really the thoughts that can be also helpful to get inspiration, and after that you can still go back with results and show them to a bigger audience in an online survey, for example. So I would not say there's a one that fails always or one that is always the best. But Anna, maybe you want to add something.
You were on mute.
Thank you. Thank you very much, Anita. Yes, I would agree on this one. That's not a suitable method. And I would quickly go to the ethics question. So for the design of the intervention, we waived for the need for the ethical approval. So we wrote a small project protocol or study protocol to the ethics, and they said whether we need an ethics approval or not. And so we actually didn't, because our surveys were anonymous and the people voluntarily take part in our study. And obviously for our RCT, we are on our ethics right now and we are almost done with it.
Congratulations on that.
Thank you so much.
But for instance, Hande, we always see that we want in our studies that we want to include people from, let's say, language minorities in Germany. And I think your research with mGender did an excellent job on seeing how we can include those people that lack skills in German and maybe even also skills in English. So there's also a critical issue that we see with the digital health apps on prescription that are even only published in German or in English. But could you maybe share a bit with us on how easy it was, or maybe what we should keep in mind when we're reaching out to people from other communities, like for instance the Turkish community in Germany, if we want to tailor interventions for them?
I think in our case it was quite beneficial that I was like I'm fluent in Turkish and I have access to this type of community. But as I said in the beginning, it's my access was limited because of differences in socioeconomic factors. But I think this is very important to involve people that I don't want to say that are part of a community, because it's just like that have a certain different, like, got a different level of access to a community. And in a case that this is not given, like in our case, I was the researcher, the primary researcher, I had access, then I would try to involve members of that community, be it like actual caregivers that speak Turkish, or in in our project, or maybe cultural or language moderators. No, how do you say it in English? Kulturmittler, Sprachmittler, Kulturmittler.
Facilitators, no?
Facilitators, yeah. I think this is very important to involve these people. This is also, I think, one of the basic parts of participation or participatory methods, that you involve the actual addressees of an intervention.
Okay, then maybe one more question to all of you, but maybe more specifically to Kevin. Do you think there is a difference in participation level and engagement, and also in motivating people to participate actively when you have a rather predefined intervention compared to when you have when you are quite broad and open towards how the final intervention will eventually look like?
Yeah, I think so. Because when you have an open intervention, as we have, so we only have an intervention frame, so it can be tailored to everything, topic settings, target groups. So it's difficult in the first instance to understand what the real target is of the intervention. So we have to invest more time at the beginning to have a common vision, let's say it like this, compared to a very fixed intervention where you're more able, or faster, where it is faster possible to create an understanding of what the main aim and main target is. So, and this would be also the idea of what I would propose later, to provide room for participation. It's not that you can just jump into it and then sorry to take it too fast. But this was our experience. When you jump into it too fast and you just start with participation, that does not work. So you need to find the right room. You need to create a safe space. You need to expect or clarify the roles, the expectations, not only for the users, but also for the researchers. It's not very easy for research to give up power, to hand over power to users. So it needs time. And this is especially true for very open interventions, which are not predefined, prepackaged. So, yeah.
Okay, thank you for already stealing my next question and answering that already. But maybe to give the floor to the other people, and maybe even someone from the audience wants to share their story. If someone would ask you for advice because they want to do their very first co-creative approach for their very first intervention design or research project, what would you advise them? In maximum 3 sentences.
I could start.
Yeah.
I would advise to really have clear who to ask which question, because you always have to keep in mind the vulnerability of patients and the time burden of health professionals. So you really have to clear what to ask and from whom you get the best information for your specific question.
Totally agree with you on that. Yes, that's a very good recommendation and advice. Who has another one?
I would have specifically for digital intervention is to basically give them some, I mean, you would co-develop, conduct a usability testing, and then co-evaluate, because that's where you get the more to the point feedback. Yes, it's important to co-develop together and to explore user needs and to see what is required out there in your target audience. But I think once you provide them with the intervention, then suddenly everything that you have done is wrong. And they would say, just change it all. And that's where you find the very good advice. Before that, it's very broad and very vague, I would say. So give time, ample time to your co-evaluation phase also.
I remember when you were at exactly that point in your project. Yes. Handa, I also saw that you were unmuted.
I think this adds to what Maham says. Actually, I wanted to say that in every stage of your, every phase of your project, that you apply some sort of reflexivity and really reflect on whether or not what you are doing is indeed co-creation, co-design, and whatever, and to be very, very clear of what type of concept you're following, and to really reflect it. Lots of stages. If it's not just becoming a buzzword in your project instead of like the actual work that you have to put into to co-create or co-design with the addressees of your intervention.
Yeah. Anita, Christiane, do you want to add any advices for the next generation of co-creative researchers?
I think Anna already showed what was our main message, but I mean, maybe another point was that we in the beginning often met to make aware what is able to be changed in the co-creation process, because there are things that cannot be changed no matter how much people wish for. And I think that's something that should be made very clear in the beginning. What are we talking about, and what is already said, or what is said for different reasons? Yeah.
Agree. Christiane, famous last words.
Yeah, I would like to stress an argument that has been raised earlier, and that is that those who co-create should lift their competencies through the process. And I think that enables also then the active engagement. And I think it is really relevant to have beneficial atmosphere also in such a development group.
Yes, I totally agree with all of you. You have definitely sparked an interest in me to make my next project one with more co-creative approaches in than I have previously used. So thank you all for your time. Also, thanks for all the participants who stayed with us for those 2 hours. Maybe if you guys want to turn on the camera once so that we can all see and say hi to each other face by face, that would be cool. And I wish you all, wherever you are on the world right now, because I saw some people coming in from Rio de Janeiro, so I guess good morning to you guys, and good evening to the European people. Have a lovely day, and I will make sure to upload this recording to our YouTube channel